CERN that have their annual meeting there. As a quick disclaimer regarding this, maybe for you watching in Lucerne, it may also be a timing now to grab a coffee, because I already warn you, there may be some overlap with the talk that Martin Hiller gave in the morning, but just as an information. Let me start with my talk, AI in hybrid imaging, aims and limitation. Maybe a little bit atypically, I start with the limitations for the talk. So there is one personal limitation. I am a physician and not a IT specialist. So the things I will show you, I know more from the clinical point of view. If you have the questions regarding more technological aspects, I'm happy to take these questions, but I may have to forward them to our team to answer them properly regarding the technical parts. Then, of course, the timing is rather short. So the title given is very broad. I will not be able to cover everything. And this is more like a personal presentation, with the goal of this talk would be first to provide you some information from a personal point of view where AI may be useful. So what aims may be targeted in PET imaging on the one hand side, and on the other hand side, where there are still limitations and which difficulties need to be overcome in order that AI has true real value in PET imaging. If we look at the current status of AI in hybrid imaging, at least judging from the numbers of publication, we can see that AI is, as compared to the other imaging modalities or radiology, was preceded regarding AI. And there are mainly two reasons that it took a little bit longer. So first is that, of course, we need large data sets, which are not as easily available in nuclear medicine as compared to radiology. And also the standardization of imaging of the different modalities in nuclear medicine is certainly much less standardized, which makes it more difficult to be than AI to be used in nuclear medicine. So let us start with the aims or the fields where I think AI may play a role. So first, as a part or task is detection, and I can illustrate you this with one study that we performed. We were checking whether AI is feasible in detecting lung cancer patients. So we took 50 patients with histologically proven lung cancers and a negative control group without any pulmonary lesions. And the question in this study was, can AI detect lung cancer? And since we had the raw data of all these scans, that means we had the continuous acquisition information from the PET, we were able to somehow simulate a reduced dose. So every bed position or scanner position in PET, in our institution, it's 2 minutes per bed. If you have the raw data, you can simulate it and sample it down. We did that quite drastically to 10%. And even we did it in a 30 times reduction to 3.3% of the dose. So the images then look like this. We have the normal image here in the top row with this highly FDG avid, so highly metabolically avid lesion in the left upper lobe, representing a bronchial carcinoma. If we go down to 10% of the dose, then it looks like this. And at 3.3%, the image looks extremely noisy. So for human eye, it may get difficult to detect lesions in that. However, we looked at the classifier performance. It was in this group quite impressive. So the AI was still performing quite well, even at the 3.3% dose level. So this as a first aim that I think AI can be really helpful to reliably and reproducibly detect lesions in PET imaging. Then as a second aim, can AI detect the different artists? Probably it could, but this is not really relevant for today's talk. And moreover, this is not even a true Rembrandt. This was generated by a so-called generative adversarial networks. These are, simply speaking, two networks with one is creating an image and the other network is somehow controlling whether the creation is properly done. And this can be used to create different types of images and can also be applied in nuclear medicine or in PET imaging, as this has been done before. For example, here we have a ground truth FDG PET image of the brain with normal injection. If we do a reduced injection, of course, the image gets more noisy, more difficult to detect lesions. And if we apply this GAN, generative adversarial networks, to this, then we might have more proper image quality. So the second aim or the second field of potential application in hybrid imaging, I feel is image reconstruction. There is already now a solution out, which is CE marked and FDA approved. It's from Subtle Medical. It's called Subtle PET. So with that software, you can reconstruct more noisy image and create images, enhance this image quality. And with that, you can reduce the time of acquisition time down to 25%, or also you could also reduce the dose. So it's up to the physician to choose what is more important. Then as a third aim or third field of application that may be useful AI was somehow I would call it a byproduct of another study. So we were actually more targeting in looking at how can AI detect pulmonary nodules, which if they are avid in PET may represent metastasis. We did it by only including the lung images. So only the images covering the lung were fed to this classifier. And then we did a slice by slice annotation telling the classifier, is there a nodule present? Yes or no. So here in C and E, there is no pulmonary lesion present, whereas in D, there is one tiny lesion. Of course, we also had the CT as a reference, and this lesion in an oncological patient is something you would want to detect because it may represent a metastasis. So again, a detection study, but as a second analysis we did, we used two different reconstruction settings, two different reconstruction algorithms. One was a Messerli, the trademark name is QClear, a little bit more modern, and OSEM, SharpIR is an older reconstruction setting. The Messerli is known to show more sharper, small FDG avid lesions, as you can see here. So it can be helpful in detecting pulmonary lesions. Also, small metastasis from melanoma has been shown that it can be better detected. And so we were in this study looking at how is the detection again of this AI classifier. Generally, the performance was quite good. So even for nodules from 0 to 6 millimeters, where the performance more than 80, sensitivity more than 80%, this is quite reasonable, especially if we consider that some years ago PET was expected to be non-detecting lesions below a centimeter. So even in these small lesions, the performance was quite good. And as a second finding, and in this for this aim number 3, more relevant, was interesting that this QClear or more modern algorithm that has this makes more sharper images. The performance was with AI using this reconstruction setting was better. So the aim number 3, I think, is a very interesting one, is that that AI may allow for a more objective image evaluation and thereby may be used to maybe optimize reconstruction settings to different clinical tasks. This leads me directly to the first limitation, because of course, if we see that an algorithm performs differently on data sets that are simply reconstructed with 2 different reconstruction settings, this may also cause uncertainty. And so limitation number 1 is, if we look at AI and hybrid imaging or PET imaging, is that there is quite some variability of data. There was a recent study from Castro that they were looking a little bit more into detail on what types of data shifts there are. It's a quite interesting overview, and they were providing a nomenclature for these different shifts. So how can data be, how can there be data variability given on different, giving different reasons? So the one I shown you before was an acquisition shift. So all these different factors may result in different quality of the data, but there are also others, for example, population shift. If we have, for example, 2 different sites with 2 different persons included, and the algorithm is trained on site A and then applied to site B, of course, especially in nuclear medicine, since the protocols are highly variable, this may cause a problem. Then the second limitation I'll just add here, I've already said in the beginning, I can cite here this work from Nenza in Journal of Nuclear Medicine. So we know, as in general, one of the largest hurdles for AI in healthcare is the need for large amounts of structured and annotated data for learning. And again, since nuclear medicine is a smaller field, this may be a little bit more difficult to have really large amounts of structured and annotated data sets. Let's go back to aim number 4, or another field where I think AI may certainly be of value in hybrid imaging. I show you here the evolution of all the children that were scanned at the University Hospital of Zürich since 2003. There are, I think, 240 patients with undergoing 440 scans. So every dot represents a scan, and every dot represents a FDG activity that was applied, so per kilogram. And we see that the injection of the dose in these pediatric patients were dramatically reduced in the last 20 years, so 84%, depending on the age group we were looking. And I can add here, I didn't add this here, but we also looked at the signal to noise ratio in this cohort to be sure that we didn't only reduce the activity and also reduce image quality. So we also looked at signal to noise ratio measured in the liver, and this was really stable over time. So we had a reduction of FDG given with stable image quality. Of course, this is a result of the technical evolution of the scanners. However, this usually is done in clinical practice by manual dose adaptation. So a dose adaptation, if we have a new scanner, is done by either subjective image analysis or by quantitative assessment, like measuring the image noise, for example, in the liver. So if we would assess these images, so these are images from the newest 6-ring scanner we have here in Zurich, in Schlieren. Here we have 2 minutes per bed position, so this is image quality is fine. And this is really done by just by readers, maybe assessing different aspects. Here also in 1.5 minutes acquisition time, the image looks fine with 1 minute still, but with 30 seconds, then I think this I would call insufficient image quality. So this can be done visually, or as said before, by signal to noise measurements. And in this case, for example, we would be able, with this acquisition time, to either reduce the FDG that we give, so by half, or we could do faster scanning if we keep the injection we give stable. But again, this is done manually and can be quite time consuming. So here we recently looked, can we use AI in doing this task I've shown you automatically? And we observed that AI is quite reasonably good in somehow mimicking the image assessment of two experienced readers. And it is also, the performance of AI is also as the same as manual signal to noise measurements in the images. So of course, this opens a new potential also, that we can make a little bit more large scale image or PET protocol optimization, since this approach is can be applied extremely fast. So in this study here, we had 200 images that were visually and manually assessed. And of course, this takes some time, whereas AI does it in a couple of seconds. Here, just to show you, we also looked at the class activation maps. They illustrate what area of the image is most relevant for deriving a prediction. And interestingly, we see that in this case, the noise that we also see here seems to be the most relevant areas. So the noisy areas seem to be the most relevant areas for make a prediction from AI. Okay, so just to sum up the aims of AI in hybrid imaging, for my view, and again, this list is really incomplete, but I think these 4 aims or tasks are really something that AI may be helpful. So first, detection, that AI may help in reliably and repeatedly also help in detecting lesions. It may do this also at reduced dose, as we have seen. AI may be helpful in optimizing the image quality. Thereby we could or we can reduce the acquisition time or the activity that we need. Then we may also use AI to do a more objective image evaluation. Thereby we can assess the performance of different reconstruction algorithms and may thereby optimize the reconstruction that we need to different clinical tasks. And as shown you now, lastly, we may also use AI for optimizing imaging protocols. On the other hand, from my point of view, the currently biggest limitations or difficulties that need to be overcome is the variability of the data. Because again, in nuclear medicine, the protocols are not standardized and they change also over time, not even only between different sites, but also on one site, there may be really changes. And also the data availability is currently a problem that needs to be overcome. Okay, thank you very much. I don't know, yeah, I'm on time. So I'm happy to answer questions, nice and short.